Hello, my name is Susie McDevitt. I'm a nurse practitioner at the University of Michigan Pulmonary Hypertension Program. Today, we're going to talk about how aggressive afterload reduction in PAH contributes to right ventricular reverse remodeling and improved clinical outcomes. So, i.e., how can we best support the right ventricle in PAH? So first, for some background, we know that despite numerous therapeutic options and advances in pulmonary arterial hypertension, patients continue to suffer high morbidity and mortality. We continue as a community to strive to figure out how to provide the best outcome for each patient. We are fortunate in recent years to have the ability to calculate our patients' overall risk with a variety of validated risk tools, and our important treatment goal is to reach a low mortality risk with escalation of PH medical therapy. The most commonly used risk stratification tools include parameters like functional class, 6-minute walk distance, and biomarkers, BNP or NT-proBNP, as these parameters have demonstrated independent prognostic value in many studies. Despite their prognostic value, these parameters have inherent limitations that we do need to consider. There are certainly limitations associated with a subjective functional class, and we believe many factors could influence a patient's 6-minute walk distance. More recently, we're learning that using invasive hemodynamics and cardiac imaging, evaluating the right ventricle, as well as our traditional risk calculators, may add incremental value in guiding our treatment decisions and impacting our patient's outcome. We know that right heart failure is the main determinant of outcome in patients with PAH, and therefore it makes a lot of sense to include markers of RV function in our overall assessment. Experts from the 7th World Symposium on Pulmonary Hypertension concluded that treatment decisions in PH should be individualized, of course, and based on multidimensional information, incorporating clinical aspects including functional class and 6-minute walk, but also right heart strain and function determined by both those natriuretic peptides and cardiac imaging and invasive hemodynamics. So back to our topic of right ventricular afterload reduction. So in PAH, RV dysfunction develops mainly because of the uncoupling of the RV function from the pulmonary arterial afterload. So this progressive vascular disease intensifies this afterload mismatch, causing RV dilatation, increased wall stress, with a downward spiral and further RV failure and eventual death. The concept of afterload mismatch can be described mathematically by RV-PA coupling, which is calculated as the ratio between RV contractility and RV afterload. We know that reducing the mean pulmonary artery pressure is usually necessary to move that RV-PA coupling toward normal. We also know from thinking about our patients who undergo pulmonary endarterectomy or balloon pulmonary angioplasty for CKEF, or our patients who undergo lung transplantation, we know that the right ventricle can recover completely when there is substantial reduction or near normalization of RV afterload. So how can we operationalize this reduction in RV afterload with PH medical therapy? What data do we have? Well, we know that aggressive treatment approaches, especially including an early parenteral prostanoid, seem to improve hemodynamics more efficiently, with more robust reduction in mean pulmonary artery pressure and PVR, which seems to be key in reversing this pulmonary arterial and right heart remodeling. So robust hemodynamic improvements, that is afterload reduction, are required to reverse the pathologic remodeling of the RV and restore RV function to normal. There's still debate about which afterload parameters we should use to guide this, such as pulmonary vascular resistance or pulmonary arterial compliance. Pulmonary arterial compliance may be a nice complement to using PVR to guide our treatment decisions. So in summary, numerous studies suggest that greater reduction of RV afterload improves RV function and clinical outcomes. Initial combination therapy and treatment regimens using parenteral prostacyclin early in the disease process provide greater hemodynamic improvement in patients with PAH. We continue to learn about the timing and the role of our newer treatment options in PAH, now considered our fourth pathway of treatment, and how this may further impact reducing afterload. Rigorous afterload reduction may enable profound reverse remodeling of the right ventricle. Thus, targeting afterload reduction using a hemodynamic-guided strategy early in treatment may significantly improve RV function. Hopefully, we will see inclusion of measures of RV function and RV afterload in future clinical trials and prospective registries. So I hope that was a helpful review of how afterload reduction in PAH may lead to improved outcomes. For more information and resources, please feel free to visit the APAP website at apapp.org. Thank you so much for joining today.